Okay, so our next chapter in the traumatic emergencies is chapter 28, which is the soft tissue trauma. This is the blood and guts and gore that everybody thinks of when they think of EMS, and it can have some pretty cool things to look at and see from time to time. However, like I think I mentioned in the previous chapter, this is just not something that it does not consume the majority of our time in EMS. So, some fairly deep subjects in here, so we will get jumping into this. Got our objectives, of course, on 641 and 642. Have a couple of multimedia videos talking about the integumentary system anatomy, which is integumentary system. If you don't know that, that is the medical term actually for the skin and the related structures, and a video on electrical injuries. So our core concepts for this chapter are going to include understanding closed wounds and emergency care for those wounds, understanding open wounds and emergency care for those wounds, understanding burns and their emergency care, understanding electrical injuries and how to care for those, and then how to dress and bandage wounds. All right, so soft tissue injuries. When we talk soft tissues, we're talking about usually the upper layers of the integumentary system. So we're going to be talking about skin, fat, muscles, blood vessels, fibrous tissues such as the different fascia or the coverings like peritoneum or pleura, or we could also be talking about things like some of the tendons and whatnot, although those tend to be classified more commonly in the hard tissue injuries. The membranes, glands, and nerves are often parts of the soft tissues, so things that lie above or outside the bone. So the skin has a number of obviously important functions. It protects us. It is our outer armor. Even better than wearing gloves is having perfectly intact skin. It's a better protection for you. The problem with this is we don't live in a bubble, and none of us have perfectly intact skin. If you have dry skin, if you have eczema, psoriasis, you have some sort of a blemish on your skin, a paper cut, a hangnail, whatever, you don't have perfectly intact skin. But it's what does a majority of protection from the germs of the outside world. It helps create a barrier for water balance. It is our plastic coating that keeps us from drying out. A significant portion of our body is water, and if that water can readily evaporate, we don't exist. Also, when the body says, hey, maybe we need to cool the body, and in the same token adjust our water balance a little bit, we can sweat, and that causes temperature regulation. So when we sweat, it puts moisture on the surface of the skin, and that moisture can then evaporate up off of there and cool us. Excretion. We excrete certain oils and substances through our pores, and often in conjunction with our hair follicles, and shock absorption. So it creates that padding there. So typically women are better equipped with shock absorbers than men are, at least on a broad spectrum. The reason why women tend to have softer features is that they tend to have a little bit more of the subcutaneous layer, or the subcutaneous fat layer. That's part of their distribution system, particularly going through maturity into adulthood. They start to deposit fat a little bit more widely around the body, and obviously certain parts of the female secondary sexual characteristics, such as breast tissue, are composed a lot by the subcutaneous fatty tissues. So obviously we have that shock absorption. There's a brief video on the integumentary system you can look at from the other one. So closed wounds, we have a couple of different things. Contusions and hematomas. Oftentimes these get thrown together in one because they really basically kind of are. A contusion is a bruise whether or not it has a collection of blood in it, and the hematoma is usually a collection of blood within the tissues itself. So sometimes you have that bruise that is there, oh, that's tender to touch, but it's not purple, or in the various stages of healing to yellowish, greenish, and whatnot. But the hematoma is where you get this collection of mostly blood, but you get some swelling and whatnot going on. That hematoma generally means that there's a little bit more tissue damage. Usually involves larger blood vessels, so it gives it the discoloration, and it's usually a little bit more dramatic. So, I mean, if you wanted to look at a few things there, they show you some areas which could be considered contusions and hematomas, but for the most part, a bruise is a contusion, whether or not it has a hematoma, which is a accumulation of blood. So we also have the major extreme of bruising and closed wounds, which is the crushing injury or crus injury, excessive force of crushing or rupturing internal organs. Generally, the solid organs don't have a lot of give to them, so they'll rip or tear, and they'll bleed rather easily. Closed crush injuries. Well, actually, crush injuries are not always closed. In most cases, they are, but in some severe cases, you will have it where the skin actually blows out from the amount of force. It's not actually a laceration, it's a blowout. So occasionally we'll have some open things involved with major crushes. Another big problem with crush injuries, though, is it breaks open all these cell membranes, causing all their toxins and chemicals to spill. It spills into the body. The body then has to try to deal with this, and in many cases, it starts clogging the drain. There's just so much tissue and particles that get thrown into the vascular system and the lymphatic system that it just overwhelms. So, assessment of a closed wound, bruising can be from an internal injury or bleeding. You want to consider the mechanism of injury. Crush injuries can be difficult to identify unless you specifically saw what happened. You can look at this injury they have pictured here in the textbook. I think almost all of us could probably figure out what caused that. It's most likely a seatbelt injury from a lap belt which was worn too high. When you're wearing a lap belt, seat belt, it's supposed to go and it's supposed to hit your hip bones. But a lot of times people will pull it way up high over their lower abdomen, and then if they get thrown around in the car, they don't have the hip bones to kind of take some of that shock, and so all of that force is then transferred into the abdomen. So if we're going to deal with closed wounds, we're going to take appropriate precautions, of course, manage ABCs. This is really very supportive, and then being strongly suspicious of the possibility for there to be a shock. So if there's a possibility of internal injuries, there's a possibility of shock. If we have other specific body parts involved, we may want to splint those extremities. If it's an extremity, if it's painful and it's swollen or deformed. This kind of goes actually a little bit more into the hard tissue traumas, but with the soft tissue traumas, splinting can be very appropriate. Stay alert for vomiting. because they're going to have potentially some spilled toxins and whatnot. And then we're going to continuously monitor for changes in transport. Sometimes they'll recommend putting a cold pack on a smaller injury to just kind of help reduce some of the swelling. In general cases, and this really is more of a musculoskeletal thing, but cold can be good for up to about 48 to 72 hours. They usually recommend after about 48 to 72 hours, heat to try to pull away some of the swelling and whatnot. But there are also other places that the school of thought is, you ice it once and you heat it, you use heat the next time. So it kind of varies. So open wounds, something a little more dramatic, something we can actually do something with. Here's our major classifications of open wounds. We have everything from abrasions up to amputations, and then some other oddballs. So abrasions are scrapes. We have lacerations, which are in the first picture there. We obviously have a laceration. Laceration is a general term for cut. We used to classify these as either lacerations or incisions, where incisions were very fine, clean, straight cuts, and lacerations tended to be a little rough and jagged. Right now we just call them all lacerations. Puncture wounds, punctures and penetrations, as you see in the second picture there. We have a puncture, and actually an impaled object is what that is referred to, as it's still stuck there. We have avulsions. Avulsions are when major parts of skin are torn or ripped away, may not be completely separated. In a classic sense, an amputation is when you have actually cut through a bone and removed a body part, fingers, toes, arms, legs, whatever. In some schools of thought, they may consider a significant loss of soft tissue as an amputation, but in classic sense, it's when bone is involved. Crush injury, like I mentioned before, significant widespread amount of heavy pressure applied to a certain body part. And then blast injuries. And blast injuries occur with various shock waves hit the body, causing various different effects at different stages, and it can blow out some different types of soft tissue. Typically the hollow organs that may contain air may burst with kind of a paper bag effect. Alright, so think about it. Does an open wound necessitate using more than just gloves as a standard precaution? Depends on the wound. We have a little half-inch small laceration on somebody's hand that's, has a steady trickle of blood. Probably not. But on the other side of the coin, maybe it's a 1-inch laceration right at their wrist that happened to catch a radial artery, and now it's spurting and spraying blood. Can an open injury affect the patient's airway or breathing? It can. Remember, you have to use the vacuum system within your chest. So if there's an open injury that actually gets into the inside the chest, so maybe it makes its way through the muscles into the chest, then it disrupts the vacuum and it can cause a pneumothorax. So treatment, open injuries. Expose the wound, clean the surface of the wound, control bleeding, provide care for shock, and prevent for further contamination. So we can't fix what we can't see. In these cases, if we have an unconscious patient or an unreliable patient, in many cases we're going to have to make them naked, simply for the fact that we can't do anything for this person. We don't know what's going on with them. So we have to expose the wound. If we have to, we may have to cut off some clothing in that general vicinity. Try not to actually cut through the damaged part of the clothing if you can avoid it, because if it happens to end up being a crime scene or something, a criminal offense, that could actually damage some evidence. So expose the wound, clean the surface of the wound. This is not something we do a lot of in field EMS just simply for the fact that we don't often have the facilities to do this. We may have some sterile water that we might use to just kind of clean it up a little bit and wash out some of the debris. We might kind of blot at it a little bit with some dressings, but we're not going to be doing any scrubbing and debridement. We're not going to be getting in there with various disinfectants or betadine or anything and cleaning that up. If you're working in a clinical setting, you may get involved with that a little bit more. Controlling the bleeding, getting in there to control bleeding. We've talked about that in the bleeding and shock chapter. So with whether we're doing direct pressure and involving maybe some elevation, some hemostatic dressings, maybe a pressure dressing, or at the point in which we may have to do a tourniquet, providing care for shock. Obviously this depends on the level of injury that we're dealing with. That half-inch laceration on the hand, probably don't need to treat that person for shock. The person that was involved in the highway speed crash and slammed into a bridge abutment, they may not be showing signs of shock now, but we should probably be proactive in the way we treat them. And then preventing further contamination. That's really one of the biggest reasons why we do dressings and bandages over most wounds, is we want to keep other stuff out of it. So whether it's insects or it's exposure to certain other bacteria and viruses and whatnot, we're trying to keep it as clean as we can. We tend to use sterile dressings when possible. Now the reality of this all is your items are sterile until the package is breached. So once you rip open the package, that 4x4 in the package is no longer sterile. It's just really, really clean. It's exposed to the outside world. If you've had this same package of 4x4s or ABD dressings or whatever in your ambulance for 15 years because we just don't use them, and the adhesives are coming apart, or it's been sitting folded up for so long, or something's been on top of it and it's poked a hole, that's not sterile, it's clean. And it may not be very clean if it's been around for that long. So keep it clean. Bandaging dressings in place after the bleeding is controlled. Remember what I mentioned before. Dressings go on wounds, bandages hold dressings. Keep the patient still and reassure the patient. So keeping the patient still, we restrict the motion, we reduce the bleeding. So treating specific types of open wounds. So reduce wound contamination. It's a big thing that we're trying to do. Hold direct pressure to control bleeding. So when we're talking about doing that, if we don't have a nice sterile or very, very clean dressing in hand, sometimes we have to rely on whatever we can get our hands on. So clean is better than nothing. So if we can get a clean towel, washcloth, t-shirt, whatever, something is better than nothing. Always check the CSM or the PMS, pulse, motor, sensory, circulation, motor, sensory, whatever, function distal to the injury to assure that there's still a good function there. Sometimes we might have a wound that's bad enough and deep enough that it has disrupted a nerve, it has disrupted an artery, and it is causing that area of the body to suffer as being insulted. So never open the edges of a laceration to see inside or to further clean the wound. They may do that in the hospital. We're not doing that in the field. If we've got bleeding under control, let's not do extra things that we can create more bleeding. So if we can, leave it alone, hold some direct pressure, apply that bandage to keep your dressing in place. Puncture wounds. Use caution. Objects may be embedded deeper than they appear. We tend to not pull things out unless we absolutely have to. So say if somebody's running around, they are running with a pencil and fall down and jam the pencil through their cheek. Well, if we need to be able to control their airway, that is going to hinder that. So that object is going to need to probably come out. So we're going to have to cautiously remove that, remembering that we have the potential for there to be bleeding on two sides of that injury, the inside and the outside. Also, if there was something penetrating in the chest and we were unable to do chest compressions, we would also consider removing that, although you have to be careful. If it's in certain spots, it could be plugging a hole in the heart. I think there's a good example. People remember the crocodile hunter Steve Irwin got stabbed with a stingray barb. His fatal mistake was pulling it out, because when it was in there, it was plugging a hole and it was keeping him going. But once he pulled it out, he unplugged the hole, was no longer able to control the bleeding, and he exsanguinated. So check for exit wounds may require immediate care. If you have a penetrating injury, did it go in one area and out another? It's not always a straight line either. A lot of different types of firearms. You'll get the bullet kind of tumble around in there. Maybe went in through the abdomen and exit through the shoulder. Or maybe it went in through the abdomen and found its way into the leg. Bullets can fracture bones as they enter as well. So you may have more than just soft tissue injury. Stab wounds are considered serious if it's in a vital area of the body. So if it's anywhere inside the elbows or the knees, so towards the core from the elbows or the knees, that's a potentially serious area. A stab wound through the hand, probably not going to be critical. Yes, they can get an artery, but in most cases it's not going to be severely life-threatening. So treatment for puncture wounds, reassure our patient, search for a second wound. It depends on what happened. Okay, could a person with a stab wound have an exit wound? Yeah, they could. Depends on how big that knife is. I've got a big butcher knife in the kitchen that I'm pretty sure would go through quite a few people if I really wanted it to. Now, talking a paring knife, you probably are not going to get an exit wound there. But there are those knives out there that you're going to have no problem. Is it unheard of that somebody would get injured with a sword? No, oddly enough, people get injured with swords regularly. You know, you wouldn't think it would be something that big of a deal, but a sword certainly could be a major problem. Assess the need for shock care. Okay, are they showing signs of shock, or are we strongly suspicious? So let's take a picture, or look at this guy here. We've got what appears to probably be a bullet, a gunshot wound that went in through his chest there, went through the lung, and then out through the liver and the abdomen. Is there any potential for there to be shock? There's all kinds of potential for there to be shock. We have damage to the lung, which has a large vascular component to it, not to mention now we have probably going to have a collapsed lung, and the liver. The liver is so blood rich that it's extremely likely that they're going to have a very severe bleed from that. So early shock care is good. So follow our local protocols regarding spinal immobilization. Spinal immobilization is changing over time. We're finding out that we immobilize, actually a lot of us have known this for a long time, we immobilize way too many people, but the reality of the situation is it's the standard of care, and the standard of care is finally starting to change. So whatever our local protocol says, if we have a gunshot wound to the back, we probably are going to immobilize and obviously transport. Impaled object. So if it's impaled and may cause severe bleeding, expose the wound area, so cut away clothing that's covering it, control any profuse bleeding by direct pressure around it, and then apply several layers of bulky dressing to kind of splint the object in place. We want to kind of support it so it's not putting pressure on things. We have to be careful in the way that we do this. We have to be careful in how much of this item is sticking out. Do we accidentally bump into it, hit it on a door frame? You know, are we picking up a piece of equipment and bump into it? We have to be extra cautious. So when we have these impaled objects, particularly things in very vital areas, say around the heart, in the eye, whatever, those kind of very, very vital areas, we have to be ultra cautious in our packaging process. So we're going to secure those dressings in place, treat them for shock, and provide rapid transport. So here they're showing an example of how they're kind of padding around this impaled object in this person's thigh. I don't know what that is. Oh, it's a knife or a fork or something, I guess. Butter knife. It's gotten impaled into their leg. And so they've built up around it with some bulky dressings there. They're kind of securing those dressings in place. They'll do another tie on the bottom side there by the blue line area on those dressings to just give it as much support and bulk as possible. Impaled object in the cheek or the chest wall. So take care that the object does not enter the oral cavity, causing an airway obstruction. And if the cheek wall is perforated, profuse bleeding into the mouth and throat can cause nausea and vomiting, as well as an airway obstruction. So external wound care will not stop the blood flow into the mouth. So if we have to treat this impaled object in the cheek, we're going to examine that wound site both inside and out. If it's perforated and we can see both ends, then we can attempt to remove that object. If we don't see something on the inside, then chances are we should probably try to leave it in place because it's not probably causing an immediate airway obstruction. So if that object is impaled into another structure, stabilize. Unless it's the chest and it's obstructing you from doing chest compressions. So position our patient to allow for drainage. So put them on the side usually that's the cheek that it went through and allows for the drainage. Monitor their airway, be ready to suction, have your suction ready to go. Dress that outside and dress the inside. You can usually get a small square of dressing in there. Oxygen and shock care as necessary. Avulsions. So a brief cleaning of the wound surface area. If we want to try to rinse it off, maybe fold the skin back into its normal position. So if we have a significant amount of skin off of our arm or a leg that's been pulled away and it's just kind of hanging there, or a good example, kind of a scalping injury, which you have this big flap of skin that's kind of just flopped over. We can try to just do a quick rinse there with some sterile water or sterile saline of some sort, place that back into its normal anatomic position. That's going to allow for it to continue to have some blood flow to keep that tissue alive, and then try to control bleeding with our bulky dressings. And if we have avulsed parts that are completely torn away or amputated in some cases, save that and then wrap it in a sterile dressing. Try to keep it moist. Do not submerge it, but try to just moisten the dressings a little bit and transport that in with the patient. In some cases, they're going to need to take and re-sew some of that tissue back into place, basically to help with the healing process. Even though that tissue probably won't survive, it's necessary for the remaining areas to help continue. Amputation. This is applied pressure dressing over the stump. This poor guy here has got actually 2 amputations. Yeah, so got a full amputation on the right leg there and an incomplete amputation on the left leg. As we can see, that's not the normal position where that shoe to be in. We're going to apply direct pressure and pressure dressings over the stump. We may have to use a tourniquet. Not always. Sometimes these injuries will be so dramatic and severe that it actually will not have a lot of bleeding because it'll cause a lot of spasming. And then pressure points to control bleeding if necessary, but a tourniquet usually is the best method. We're going to wrap that amputated part, so what's detached from the body. We're going to wrap that in some sterile dressings. Put it in a plastic bag. Some places are going to say moisten those dressings just a little bit to keep it from sticking to the open parts. And put it in a plastic bag and then put it down into either some cold water or with some cold packs or on ice. But do not immerse that part directly into the icy cold water. If we do this, the water will be absorbed into those tissues and it will basically destroy those tissues. If we have any chance of reimplanting this amputated part, the tissue needs to try to remain as healthy as possible. We put it on ice in order to slow down the metabolic processes that are going to start to deteriorate this product or this piece of tissue. But putting it in the water, again, it's going to waterlog it and it's going to cause severe damage. Treatment for genital injuries. We're going to control any bleeding that we see with that. Preserve any avulsed parts. Consider if the injury suggests another possibly more serious injury. We're talking genital injuries, we're talking areas of the pelvis. The pelvis has a very high vascular content. Remember, I mentioned that you can lose up to 2 liters of blood, or even closer to 3 liters in some cases, of blood in your pelvis. So that could be suggestive of, well, there was enough damage here to cause this. Did it cause some pelvic injury? Be calm and professional. Maintain that patient's dignity. If we have the ability to provide a same-sex EMT, that would probably be preferable. And then dress and bandage any certain wounds that they may have. Burns. Burns can involve more than just that skin level structures. We can have burns that get so deep that they get into the muscle and bones. And when we're talking the depths of muscle and bones, we're talking about potentially life endangering for sure, but potentially limb amputations and whatnot, or at least extreme cases of the of reconstruction that may be necessary. If the respiratory structures are affected, we can have a lot of sudden swelling that's going to cause life-threatening obstructions. The airway can swell up so quickly that it swells shut. Don't let the burn distract you from other things such as spinal injuries or fractures. Burns are very, very ugly. There's a bad smell that goes. Burning flesh, burning hair is just terrible, terrible smell. Very distracting. Usually very, very painful. But remember that they can also have other injuries going along with this. So our assessments of burns, we classify these by their agent and their source, their depth, and their severity, or the type of tissue damage. We basically have 3 major severities of burns there: the superficial, the partial thickness, and the full thickness burns. These were formerly called the 1st degree, 2nd degree, and 3rd degree burns, respectively. So a 1st degree would be superficial, 2nd degree was the partial thickness, and what we formerly called 3rd degree is the full thickness burn. Some places they also referred to as the 4th degree burn, in which it actually burned a part off or burned it away. So our superficial burns, these involve only the epidermis. There's reddening, maybe some minor swelling, usually not ridiculously painful, more annoying painful than anything. All of us have suffered a superficial degree or superficial burn at one point or another. If you've ever had a sudden burn, you had at least a superficial burn. Occasionally we see some burns that are at the point of partial thickness. So usually these are painful and annoying for a couple of days, and then you really kind of are over it and healed. Partial thickness burns, formerly known as second degree. This is the epidermis that is burned all the way through, and we're now burned into the dermis, or the living working layer of the skin. These are usually deep burns. They're intensely painful, very, very painful burns, and there will usually be blistering and then some mottling of the skin. Once you have blisters, that's really the point in which we say you've gone from superficial to partial thickness. The blisters are the body's way of attempting to cool that burn, and some of the coagulation of the tissues, or the tissue is broken down, and some of the content remains in those blisters. The partial thickness burn, if you haven't had one, usually these people do need some sort of a medical treatment, if for nothing else, to clean it up and pain control. And then we can talk about full thickness, or what formerly was called third degree burns. This is all layers burned. We're now burned down into the muscles and the subcutaneous tissue. There are blackened areas surrounded by dry and white patches. The other thing to consider about burns is a lot of times you don't have a single, if you have a third degree or a full thickness burn, you don't only have a full thickness burn. You have the center of the injury, which is full thickness, and then usually around that you'll have some partial thickness burn, and then around that even you may have some superficial burns. So you may have varying degrees of burns from one single incident on the same patient. When we look at severity of burns, we also look at how much body area is burned, and it helps to estimate the extent of the burn area. The adult body is divided into 11 major areas, each representing 9% of the body's surface area. So this is called the rule of nines. So if we look at the adult, the entire head is 9%, so front and back together is 9%. So if we would only burn half of it, we'd have 4.5%. Each arm is 9%, or the front of the arm 4.5, the back of the arm 4.5, the top of the arm 4.5, and the bottom of the arm 4.5. Either way, you want to go with that. The chest is 9%. The abdomen is 9%. The upper back 9%. Lower back 9%. The front of each leg is 9%. The back of each leg is 9%, and then 1% left over for the genital area. So if you add those all up, you end up with 100%. This is different on the different sizes of patients that we deal with. We have kids that generally have larger heads, particularly infants. So we'll have 18% allotted to heads, and some is taken away from the legs. Arms generally stay about the same. Chest and abdomen stay about the same. So it's basically the legs that get stolen from. We also sometimes will talk about the rule of palms. This is kind of an old rule. It's kind of going out of favor, but you can basically say if you look at the patient's palm, their palm is roughly 1% of their body surface area. So if you guesstimated by, well, how many of their palms would it take to cover that burn? Well, it'd take 3 palms. Well, then 3%. It's kind of an older school of thought. It's not used as much anymore. Not always quite as accurate as they once thought it was. Burns in the geriatric and the pediatric patient. We have minor burns in a young adult can be fatal to a geriatric adult. And in infants and children, they have a much greater relationship of body surface area to total body size. So it's resulting in a greater fluid and heat loss from those burns. So either way, we have people who don't do a good job of maintaining their own body heat. They may have a compromised immune system. They may not have a cardiovascular system that works quite as strongly as the standard adult does. So these are some things that we have to keep in mind. So some minor burns for an adult become a major burn in some of these other populations. Thermal burns. So we're going to use sterile dressings. We're not going to apply ointments, sprays, butter. Whoever decided that we should put butter on a burn, I don't know if they've ever made a grilled cheese, but I'm pretty sure you butter the outside of that to help burn your bread when you're making grilled cheese, so that doesn't make a lot of sense. It actually traps heat in. It doesn't do a good job of dispersing it. So no ointment sprays or butters. That's something we'll let the hospital put certain types of salves or creams on. We're not. Do not break blisters. If we break a blister, we open a route for possible infection. So we leave the blisters alone if we can. Dry dressings are usually what we'll use. If it's a smaller burn, we may moisten the dressing with some sterile water, and that will help kind of cool the burn a bit. But if we would have, say, somebody who has 18% of their body burned, we're probably not going to douse them in water because they're losing their ability to maintain their body heat anyway. So we run the risk of making them hypothermic, actually. Chemical burns, we're going to wash away chemicals with copious amounts of water. If it's a dry chemical, we can try to brush it away and then flush it with water. If we're going to do this, be careful you don't expose yourself to these chemicals. And hopefully, if you're also going to be trying to rinse away chemicals, somebody has an idea what that chemical is and what it does. There are certain chemicals that react very violently with water. So if we have this chemical burn, we're going to remove any contaminated clothing that they're wearing, because as long as that contaminated clothing stays on them, it's continuing to burn them. We're going to apply some sterile dressings, and we're going to treat for shock as necessary. Electrical injuries. So electrical injuries, this severe damage occurs through the body by disrupting the nerve pathways. We typically will have entry and exit wounds, whatever they touch. So in many cases the entry wound is in their hand because that's what they touched the device with. Although there are certainly accidents that occur where you may have backed into something or put your head into something or whatever. And then the exit wound is usually as close to the grounding spot, so in many cases it's the feet, as possible, where the electricity leaves the body. Respiratory and cardiac arrest are very, very possible. Bones can fracture from very violent muscle contractions. Remember, your muscles work off of electricity, your nerves work off of electricity. Those are going to be your major tracks. So when we have nerves and muscles being exposed to excessive amounts of electricity, they kind of go haywire. They go into overdrive in what they're doing. We're going to try to provide the best airway care we can for these people, be alert changes in their cardiac rhythm. The cardiac arrest is very, very possible. It happens many times with severe electrical shock. And then treat for shock and provide oxygen. Obviously, any of these injuries that involve major forces like this, we need to consider calling for ALS. So, you have somebody who burned themselves by pouring some grease on their hand. They probably don't need a paramedic. Somebody who was exposed to 440 volts of electricity, that's significant shock. They probably do need paramedic. So ALS. Care for spinal and head injuries usually also gets considered here just because a lot of times they get thrown around with an electrical injury. Extremity fractures, you'll want to consider immobilizing those. Evaluate their burn sites. It's not pertinent that you identify the entry and the exit. Just finding them and dressing them is good. And then you can try to cool the burned areas and apply sterile dressings as necessary. Video on electrical injuries. So dressing and bandaging. A dressing, again, that's the material that's applied to the wound itself to prevent bleeding and prevent contamination. They're showing a pressure dressing in this picture. That is not a pressure dressing. They're simply trying to do a direct pressure with that. And then in the second one, they're trying to demonstrate what's called an occlusive dressing. An occlusive dressing gets used when we don't want air to pass through it. Most of our dressings are mesh, more or less, so air can pass through it. In the cases in which we may have an injury to our neck or our chest, we run a risk of having air pass through there, and it could pass into an artery or a vein and cause us to actually have a stroke or pulmonary embolus or something along those lines, or it could cause us to have a pneumothorax. So an occlusive dressing gets used. I want to talk more about that in a second. So a bandage is any material used to hold that dressing in place. So in most cases it's cling, like they show here. Another example may be tape. You may just use simple tape to hold a dressing in place. We may also consider something like they refer to as co-band, which is kind of a self-adhesive roller bandage. We have like ACE wraps too. So to dress a wound, we're going to expose it. We're going to completely cover that wound area with the dressing. We usually carry various sizes of dressings depending on the type of wound we're dealing with. Those dressings should not be removed unless the bulky dressing gets blood soaked, and then a new one needs to be applied to maintain direct pressure. If we have too many layers, again, we are going to disperse our pressure. Control your bleeding by direct pressure or by pressure dressings. And then also you can consider hemostatic dressings as well as or hemostatic agents and a tourniquet. So bandaging open wounds, do not bandage too tightly or too loosely, and do not leave loose ends. So bandaging too tightly can restrict blood flow. Bandaging too loosely obviously kind of defeats the purpose. You're not kind of more or less sealing it off. And then to not leave loose ends, because those are going to get caught on something. They're going to get unraveled. They're going to get drugged through some chemical or whatever. Do not cover the tips of the fingers, the toes, so we can observe the skin changes. So usually we're going to be rechecking capillary refills in their fingers or toes, make sure that they're still adequate, and then cover all the edges of the dressing. So that's why tape often isn't sufficient, because we're just not covering all the edges. A little bit more on your occlusive dressing. We're going to talk specifically about that in the probably the neck and chest injury chapters. But occlusive dressing just requires some sort of a barrier to go along with it. The occlusive dressing, many times you can make an occlusive dressing just fine. They sell Vaseline gauze, which is intended to be an occlusive dressing, and that Vaseline gauze is a piece of mesh gauze that's impregnated with petroleum jelly, and that petroleum jelly kind of creates an air barrier, so it seals it up. Well, that's all good and fine, but what they don't tend to tell people is if you've ever tried to stick tape to petroleum jelly, it does not work. So even if you don't have a Vaseline gauze or petroleum jelly gauze, as long as you have a piece of gauze and a piece of plastic, you can create your own occlusive dressing. And even if you're using that, you need to apply Vaseline gauze, you still need to apply something over the top of it so you can stick it down. So you'll put your dressing directly on the wound, and then take that plastic or that packaging. The Vaseline gauze comes in usually a foil package, so you can use the foil, apply that over the top of the dressing, and then you're going to tape it down on 3 sides. So you make 3 sides taped down, leave one side open, and that acts as a flutter valve. So if air has to escape, it can get out that one side that's not completely taped down, but air can't get sucked back in because there's kind of the vacuum technique that goes on there, and it prevents air from easily re-entering. So soft tissues can be open or closed. We can have contusions, hematomas, crush injuries, open wounds, abrasions, lacerations, avulsions, amputations, and crush injuries. For open wounds, we're going to expose them, control the bleeding, and prevent contamination. Standard precautions are very, very important. Burn severity is considered by their source, the region affected, depth of the burn, the extent of the burn, the age of the patient, and then other patient illnesses or injuries. There's a lot of good information in the chapter that you should really consider. Burns, and you should spend some time looking over each of the areas, but there are certain areas that we get a little concerned with. So if we have any functional area, such as hands and feet, genitals, the face, the airway is involved, those are obviously very, very, very serious burns that we need to be concerned with. So we want to try to stop the burning, and usually that's done, in most cases by flushing the burn. Cover that thermal burn with a dry, sterile dressing. Flush a chemical burn. Brush away any dry chemicals. Protect yourself from those. Protect the airway, oxygen and ventilation. Treating for shock and transport. And we're going to treat electrical burns. Be sure that the patient is safe. Do not go running in there touching your patient immediately until somebody has cleared the scene. You may have to stand on the outside looking in for a while. So protect their airway and their breathing, circulation. Be prepared for cardiac or respiratory arrest. Treat for shock, treat the burns, and transport. Remember the soft tissue. The body is made up of skin, fatty tissues, muscles, blood vessels, fibrous tissues, membranes, glands, nerves, and that skin has a lot of major functions such as protection, regulation that it provides for us. Open or closed is a reference to the soft tissue and is dictated whether or not the skin is still intact. Closed injuries must be evaluated with consideration of what's underneath there. Open injuries should also be considered with that. If we get stabbed, where do we consider the possibilities that the knife could have gone? Open injuries are typically easier to visualize, but they can often mask underlying problems. Burns involve immediate destruction of tissue and can have long-term effects both physically and emotionally. The biggest concern that we have with people with major burns is, number one, fluid shifts are going to be huge, and secondly, the probably most common reason why people don't survive a burn is they die from an infection. So being safe, got to remain safe. Is the hazard still present? Goal of dressing and bandaging is just to prevent bleeding or control bleeding and preventing infection. So some questions for you to consider. Does a patient have a patent airway and breathing is adequate? If the wound is penetrating, is there an exit wound? What is the best way to immobilize an impaled object? Is there respiratory involvement with a burn? Have we irrigated a chemical burn sufficiently? And usually we say for a minimum of 20 minutes. Does the electrical burn have an exit wound? Is the bandage secured well to hold the dressing in place? So our critical thinking question: we have a 21-year-old male lacerated his anterior elbow when he fell through the window. There's a lot of blood around the patient. Bystanders have applied numerous towels and washcloths over the wound, at least 3 inches thick. There are so many dressings on the wound that you still can't tell if it's bleeding or not, and the patient's alert but pale and anxious. The radial pulse on his uninjured arm is rapid and weak. How much assessment would you do, or should you do, and how do you do it without making things worse? So in this case, you probably are going to have to pull away several of those towels. Before you do that, you should have some dressings ready to go, so you can dress that wound and approach that wound with an aggressive stance. If he's got a weak radial rapid pulse, he's got a lot of bleeding, we should be strongly suspicious for shock and treat him as such. Laying him down so blood can get to his brain, elevate his feet as necessary, keep him warm, control the bleeding. If necessary, we could splint that area, consider the hemostatic dressings and whatnot.